months of the year, of the academic year. So we have a special guest for you that promises to be terrific, and it's about cancer. And we celebrate today Dr. Theordore Segal. So this is the Theordore Segal lecture, and I'll tell you a little bit about him. But before that, a few comments. First of all, I want to celebrate Sanjay Srivastava. Many of you know Sanjay. He's a professor of medicine. He's in the Division of Cardiovascular Disorders. And Sanjay, who's a terrific researcher, just got announced that he obtained a Superfund grant from the government. And Superfund grant are these big multi-million-dollar grants that are provided for groups. This is not a one-person deal, to address human health as it relates to environmental hazards and how to address environmental hazards and how it relates to cardiovascular disease in his case. So congratulate Sanjay when you see him, because this is a big deal, okay? I also want to celebrate 3 or 4 people very quickly. And as you know, throughout the year, I bring you the names of people who have changed the way we think about medicine and biology and human nature. And today there are 3 people that I want to bring up related to cancer, because this is a cancer presentation. But there are 3 people who've done things that you probably would have not considered related to cancer. So let me explain. The first one is Sir Henry Dale. He was born on this day back in June of 1875. Sir Henry Hallett Dale was an English biologist and physiologist who isolated in 1914 acetylcholine. And he actually was the one who put forward the whole area of cholinergic signaling. And today there's a lot of interest in cholinergic signaling in cancer cells, but also in host environment, how that affects cancerogenesis. And for that, he won the Nobel Prize of Physiology or Medicine in 1936. I also want to remind you, Francis Crick was born on this day, 1916. You know Francis Crick. He won the Nobel Prize with James Watson and Maurice Wilkins in 1962 for the discovery of the molecular structure of DNA. And as you know, if we don't pass DNA in the right way, you may develop a cancer cell, although that clearly is not enough. And then we celebrate Daniel Mazzia. Daniel Mazzia died on this day in 1996 at age 83. Why I bring this to you is because he's an American cell biologist who is notable for his work in nuclear and cellular physiology as it relates to cell reproduction. He was very intrigued by the process of mitosis, and he was the first to isolate in much earlier than that. He isolated the mitotic apparatus. Okay, he isolated it. You can study it and you can evaluate how these things work or does not work in certain conditions. And for that, he was celebrated greatly in 1951 with a number of prizes with his colleague in Japan, Katsuma Dan. So all of that brings me to Dr. Theordore Segal. Why do we celebrate Dr. Theordore Segal? Well, this was established in 1982. He was an outstanding member of the academic community and a humanitarian. He was actually a dentist, an orthodontist, rather than a physician, so that's intriguing. And he obtained his degree in 1954 at UofL, School of Dentistry. He went to residency at Tufts University. He joined the faculty of UofL back in 1969. He developed the Department of Orthodontics. So if we have a Department of Orthodontics, it was because of Dr. Segal. He did a number of works. He was past president of the Louisville and Kentucky Orthodontic Societies and contributed to the lives and careers and education and mentorship of generations of orthodontics that are walking around today. And so in 1982, he had an untimely death due to cancer, and his family requested a lectureship in his honor to medical oncology. And that's why we celebrate his legacy today by bringing somebody who's an academician, who's been known for his efforts in this area. He's going to bring us some important information. So to introduce a set of introductions, I bring to you Beth Riley from Medical Oncology, who's going to start us today.
Thanks, Jesse. So I'm very excited about this topic and to have Dr. Miller here with us today. June is Cancer Survivor Month, and as our treatments become more successful, we're dealing with a larger population of patients who live longer, both with sequelae of their cancer as well as sequelae of their treatment. And all of us as a medical community, particularly in the House of Medicine, need to be better adept at taking care of these patients. We're lucky that Dr. Miller has had a close relationship with 3 of our fellows. And so I thought it only appropriate to introduce him with somebody who knows him more personally than I. And this is our incoming chief fellow, Dr. Gossain.
Thank you, Dr. Riley. I'm pleased to introduce our speaker for today. Dr. Kenneth Miller completed his internal medicine residency at Yale before moving on to NIH for his Hematology fellowship and then to Johns Hopkins University for his Oncology fellowship. Dr. Miller has devoted most of his medical career, towards teaching all around the world. He has introduced and started a lot of cancer programs in Africa, along with his focus in survivorship and global oncology. After serving as the director for survivorship program at the Dana-Farber, Harvard University, and then at Yale, he moved back to Baltimore, where AJ and I were lucky enough to work under him as a medical student and as the residents. Most recently, Dr. Kenneth Miller has been appointed as outpatient director at University of Maryland. This is very recent. Congratulations on that. But honestly, today it is my privilege to welcome my mentor, Dr. Kenneth Miller, to University of Louisville Grand Rounds. Can we please put our hands together for Dr. Kenneth Miller?
Good morning. Firstly, it's fun to be here. It really is. One of the greatest pleasures that I've had in the last few years has been having the opportunity to be a teacher and hopefully to be a mentor. And 2 my most favorite people you have here, and you'll have a third. Rahul and AJ and Shruti will be starting in about 2 weeks. So it's been a wonderful part of my life, and watching them succeed is icing on the cake. Anyways, what I want to talk about today is cancer survivorship, to look at what I would call the seasons of survivorship, the natural history of survivorship, and then really to drill down some on what do cancer survivors need and perhaps what don't they need. Because there are a lot of cancer survivors. There's essentially 15 million now. So this is, now the picture on the left, you might say, who's that man? That's me. Anyway, a long time ago, my wife and I, that's Joan. Joan and I met in college at Tufts, and we were married, actually, at this point, it would be 37 years. And those are our kids. And then life can change in a sunset. And, we write in our histories and physicals, we're writing this all the time. Mr. Jones is a 50-year-old man who was in good health until they've had chest pain or had pain in the right lower quadrant or had a fever. Mrs. Jones is a 65-year-old woman who was in good health until. And Joan, my wife, was in good health until 1999, when she, in fact, developed fever and really had an FUO that went on for several months. And a lot of pain, a lot of rib pain. And we really could not figure out what it was, and it was bad. And then she got better. And then about 3 months later, Joan writes here, this is from, she's a writer, so she kept a diary. She said, then 4 months later, in June 1999, trouble started brewing again with the black and blue marks on my legs, swollen ankles, fatigue, shortness of breath. I was severely anemic, and my white count was unusually high. And she was diagnosed with AML. So it's at this point, it's about 18 years ago. This is Joan's CBC at the time, and I remember it was around 12 o'clock at night. It was on a Saturday. I'd gone back to the hospital to admit a patient, and I called the lab because Joan had had blood tests the day before, and I said, do you have the results on Joan Miller? And they said, well, we're holding it for the pathologist. I said, I said, can you read me the upper part? And they did, and Joan's white count was about, it was 30,000, and her hematocrit was about 19, and her platelets were around 19 also. So she had leukemia. She had AML. And Joan, actually, that's the Johns Hopkins Oncology Center on the left, where I had been a fellow about 13 years earlier. I had walked down that hall hundreds of times as a fellow, and this time I was doing it as a husband. And I said, Joan's a writer, and so she said, take pictures. She said, one day I'll write a book, which she did. So this is Joan. It's around midnight, about 2 days later, starting chemotherapy. There are some things, I actually want to make a comment on the picture on the right. That's her nurse, Marcy, who I remember from 18 years ago. I haven't seen her since, but she actually started that process of survivorship for us in as positive a way as possible. She, just a very positive spirit. She said, Joan Miller, she looked her right in the eye. She said, you will get through this. And fortunately, she did. And that's Joan coming home from the hospital after induction chemotherapy. She had lost a lot of weight. She actually had a walker. She had developed a fasciitis. I mean, it was a horrible experience in many ways, but she did make it home, and these are the kids celebrating. And in a sense, this was the beginning of that phase of survivorship. And Fitzhugh Mullen is a pediatrician who was diagnosed with a mediastinal germ cell tumor. This was in 1980, well, probably in the early 80s. And he wrote in the New England Journal of Medicine, a person is a cancer survivor from the moment of diagnosis and then for as long as they live. And with that in mind, because, thankfully, more and more people are getting through and beyond cancer, and living for years and decades and living out a normal life. So the number of cancer survivors continues to grow. I think I pushed the wrong button. There we go. Anyways, in 2003, it was up to 10 million. Now it is about 15 million, and it is projected by the mid-2020s that it will be up to 20 million cancer survivors. So in this article by Fitzhugh Mullen, this was actually New England Journal of Medicine, he talked about 3 phases of cancer survivorship. Acute survivorship is that time of diagnosis and treatment. Extended survivorship is a period of surveillance, typically often thought of as 5 years. For some diseases, the greatest risk of recurrence is more front-loaded. It may be in the first 2 to 3 years. For others, it's more extended, but essentially a period of surveillance. And then permanent survivorship is a time when people are going on with their lives, where they'll say, I have a history of breast cancer, I have a history of melanoma, whatever it may be, but it's not at the forefront of their thinking or of their medical team's thinking as well. Well, a lot has changed since the 1980s when Fitzhugh Mullen proposed that schema, and we all know about this: targeted therapies, biologic therapies, high dose therapy with stem cell transplant. A lot of patients living as with cancer as a chronic disease. It really was not heard of in the 80s. And more patients living long enough to develop second cancers. So this is a look at 3 decades of survival curves. And I think what we'll do, we'll start on the right and then we'll move toward the left, because the left one I don't think is labeled. Well, if you look at lung cancer mortality, 3 curves. This was in the 1980s to 85, 90 to 95, and 2000 to 2005. The curves were pretty much superimposed. There was a small amount of improvement with the top curve. And now we're starting to make some headway. Breast cancer mortality, there has been some progress. And in fact, that top curve is getting, for stage 1, is getting close to, actually that says all stages, is getting closer to mid 90%. So by the way, the one on the left, 3 survival curves from the 80s, the 90s, and the 2000s. Which disease do you think that is? CML. Yeah, it's CML because of Gleevec. I mean, it is pretty amazing. But here's the point I actually wanted to share with you. If we take that population of 15 million cancer survivors, I have to say, I've seen this graph before, but if I hadn't, and you would ask me, well, what percentage of those survivors, we're calling survivors, are long-term survivors, more than 5 years? I might have guessed it would have been in the 30 to 40% range. Why? Because most of my day I spend taking care of people who are in acute survivorship. They're just diagnosed, they're treated, we're trying to get them better. But if you look at this graph, it's really 69% of patients are more than 5 years out. So really, if you think about the population of cancer survivors in Louisville, in Baltimore, nationally, it's 70% of those people are long-term survivors. Now, I realize, in a sense, we as oncologists, as clinicians, we can't take care of everyone. But I think it does give a moment of thought about really all the people that you collectively have treated who are out in the community. And the question being, what are their needs? What are their health problems? And how can we also be of some service to them? So with that in mind, in terms of thinking about cancer survivorship, that acute period of diagnosis and treatment is profound. I remember, I just shared with you Joan's story about being diagnosed. It's a memory that's viscerally embedded in Joan and I and our kids. But in a sense, that is a diagnosis and treatment is a small part, we hope, of someone's lifespan. So the top graph, excuse me, that's a picture of Joan and I. Joan was 42, that's the black. She was diagnosed with AML and was treated about a year. Did well for about 8 years, and then actually developed breast cancer and was treated for that. But again, the point I want to make is that red part of our lifespan, Joan will be 60 next year, diagnosis and treatment is profoundly important, but a small part, we hope, of her life. This is a woman who is a childhood cancer survivor, again, diagnosed probably at age 7, treated for several years, and now is an adult. This is a woman named Ann Burke I took care of, who was one of the original Rockettes. So I'm actually really always happy to share her story. So she was diagnosed with breast cancer at age 85. And again, so in the terms of a whole lifespan, a person's life history, our hope is that the acute survivorship is a small part of it. Let me say a couple things about the seasons of survivorship. I wrote a book at this point, it's about 10 years ago, called Choices in Breast Cancer, How Women Make Choices. And so a lot of it was women's stories about how they navigated the diagnosis. There's a woman named Wanda. She says, the news came like a dreaded, jangling phone call in the middle of the night. You have breast cancer. When I heard the words, I felt like ice water was poured through my veins. And not all of it, by the way, is somber. This is Ann. The doctor came to me with a sad expression. I tried to cheer him up. I assured him that we would just get going and do what had to be done. I had dance classes to teach and many shows to put on. I chose mastectomy. So that was Ann. This is a woman named Karen, and I share this in terms of extended survivorship. It was about 4 years ago since I completed my chemotherapy. There isn't a day that I don't think about cancer, though it's not hourly. And finally, permanent survivorship. Cancer is just one of the many issues that I've faced. Cancer helped me. I love more. I care more. My life means more to me. And by the way, that the concept of benefit finding or post-traumatic growth, I think, is really an important one. And again, not everything is somber. This is Lily Shackney from Johns Hopkins. She said, my 12-year-old daughter asked whether the surgeon would be moving my right breast into the middle of my chest after removing my left one. My first thought that this would create a new condition, the uniboob. So, and I hope it's okay to use a little bit of survivorship humor. Okay. I do think, however, that there's other parts of survivorship, and again, acute, extended, permanent. But those of us who are treating people with cancer, there's another finishing treatment is what I call transitional survivorship. This is a woman named Ange. So when I was in treatment, I had all the steps laid out in front of me. I knew what I had to do to fight this disease. Now I find myself wanting to go to the clinic, to get chemo, to do something. And it is a time of anxiety for many people. And then I think the other season of survivorship, which is different than it was, is what I would call chronic survivorship. This is actually my father-in-law, a while back, Mel Heller. And he writes, I had it just 10 years ago, and I'm taking Gleevec, and I'm in remission. Is my peripheral neuropathy and aortic stenosis related to the Gleevec? I don't know, and I really don't care. But he was part of a very large population of people who were stable. And this is a woman named Marianne who writes about her journey with breast cancer. Long-term survivorship with stage 4 breast cancer. And there's a lot of people that we see during our days as oncologists who are like this. The topic of long-term living with cancer, really there's very little written about. So I mean, I could make some presumptions of what that experience is like, but I actually encourage, one thing I try to do now is when I'm seeing a longer-term cancer survivor, I say, let me ask you, how much do you think about cancer? And most of the time people will say, well, not often. Sometimes people will say a lot, and it actually really can uncover it as a problem. So this is from an article that I wrote in 2009, but just looked at the seasons of survivorship. Acute survivorship is on the left, diagnosis and treatment. Transitional survivorship, extended survivorship. And let me go through this briefly. Living with cancer is over there, sometimes for a short time, sometimes for living in remission for years. This I think is worth thinking about too. Again, when you think about long-term cancer survivors, most are cancer-free and free of cancer. They're really doing quite well. I mean, they're not having late and long-term effects. They're really going out with happy, healthy lives. Some cancer survivors have late and long-term problems. And a woman who's had a mastectomy or has had radiation and now has lymphedema, a person who may have chronic post-thoracotomy pain syndrome, and there is some of that, people with a cardiomyopathy, et cetera. Developing second cancers, like my wife Joan, some of it is simply by living longer, some of it is genetic risk. And finally, secondary cancers, which in adult cancer survivors is relatively low, but something to think about. So again, most are cancer-free, free of cancer, but there's a mixture. As you design cancer survivorship programs, it's important to think about which groups do you really want to serve, because you may not be able to serve all of them. This is a slide that talks about late and long-term effects of treatment of childhood cancer. And you'll see, I'm going to show this for a reason, but there's a lot here. There's bone problems, lung fibrosis, cardiomyopathy, et cetera. And the field of childhood cancer survivorship is very well developed. They have tremendous amounts of research and statistics. And there's a lot of toxicity late and long term. So this is cumulative incidence of grade 3 to 5 physical health conditions in survivors of childhood ALL, brain tumors, or CNS tumors, and Hodgkin's lymphoma. And if you look at the Hodgkin's group, or the CNS for that matter, it's 40 to 50% of those children at 30 years later are continuing to develop these health consequences tied to their treatment. So in a sense, what that has, and I think the field of child cancer survivorship has moved forward our understanding. It's really sort of set us up to look at a medical model. If we look at the 4 domains of how an experience can affect someone, there's medical, there's emotional, spiritual, financial. And we tend to think, I mean, we're clinicians, we tend to think of the medical model. But as I'll show toward the end of my talk, I actually think in adult cancer survivorship that we may want to look at it differently, that a lot more of it may be the emotional, spiritual, and financial for that matter. just some examples, I mean, again, of some of the things to look for. That's Fitzhugh Mullen in the top. He had a medial sternotomy. He ended up with radiation therapy. He had a lot of problems. He has had throughout his lifetime a lot of problems related to that because of really constrictive lung disease. So he's got a busy, active career. He's was one of the surgeon generals or assistant surgeon general at one point. The second picture, that's my wife Joan, who developed second cancer, and that's a woman named Ellen Stovall at the bottom, who started the National Coalition for Cancer Survivorship, who had radiation for Hodgkin's, and then developed breast cancer as a secondary cancer. So all those things are possible. Though again, I'm going to share most cancer survivors are doing quite well. Here are some of the possible late and long-term effects. I'm not going to go through all of them, but just, sometimes it's from the disease and sometimes it's from the treatment, surgery, radiation, chemotherapy, etc. All right, so some quiz questions. This is audience participation time. A 20-year-old woman is diagnosed with stage 2B nodular grossing Hodgkin's disease with a bulky mediastinal mass. She's treated with 6 cycles of ABVD and received radiation therapy to a mantle field and a periaortic field below the diaphragm. 10 years later, at age 30, she goes to her new primary care provider and lets them know she was treated for Hodgkin's disease and has had no problems since then. So they discuss normal 30-year-old female screenings. Is that okay? So, well, I mean, it's good to talk about screenings, but how is she different? Anybody? Yeah, she's high risk. And high risk for what, by the way? Yeah. So she's at risk for breast cancer, premature cardiovascular disease, pulmonary fibrosis, colon cancer, all the above. So all the above, yeah. All the above. The colon cancer is sort of interesting, but some of it's from irradiation. So what breast cancer screening would you recommend? And by the way, the reason I'm sharing this is because I think actually this is part of what we can do as oncologists in terms of educating primary care doctors. I'm not doing this to quiz you, but really just to say that, I mean, firstly, most primary care doctors are really quite good at this. But I think every time we send a letter, a follow-up letter on one of our cancer survivors, it's an educational opportunity. Talk about, geez, Barbara is 10 years out from her Hodgkin's. She had radiation therapy. She's at higher risk of breast cancer, and to talk about screening. So what would be recommended? Annual mammograms starting 2 years after radiation, mammograms and MRIs 2 years later, 8 years later, yearly breast exam, no idea. Anybody? I would say C too. MRI is really is not been decided whether that makes a difference. I actually think it's useful, but again, typically, especially now because screening with a mammogram, there's some controversy and how late should we start? But for this woman, she should have mammograms. It's important. What cardiac care? I think this is an interesting one too. What screening? 5 to 10 years later, consider her in high risk for lipid management, healthy diet, optimal blood pressure, all the above. All the above. I agree. And let me make a point about that too. We can't take back the radiation therapy. We cannot take back the adriamycin that she had. We don't want to. She's been cured of that disease, but she is at higher risk, and we can't change certain things. But we can do screening. We can make sure that her cholesterol is really, really good. We can make sure that she's or try to get her to exercise. We can make sure that she's got good blood pressure control. What we can do is reduce comorbidities. And again, we can do it. But as I'm going to show you in a little while, I don't know that we describe her as going back to a primary care doctor. She likely is not seeing one of us. Okay? And so one of our only shots at secondary prevention and good health for this patient is before she leaves oncology, which is, I think will happen, is again educating her primary care doctor or doctors. Let me do this one very briefly. A 45-year-old man with squamous cell carcinoma of the head and neck is treated with bilateral neck and supraclavicular radiation chemotherapy. 10 years later, he's free of cancer, but is at risk for hypothyroidism, dry mouth, there's hypothyroidism again, carotid artery stenosis, secondary cancers, all the above. Yeah. And I have seen 2 patients now relatively young people with stroke from carotid artery disease. So again, we cannot take back the effects, and think of all the young patients now with head and neck cancer, HPV-related, getting radiation therapy, living out long lives, but at some risk. And so this is our opportunity both to educate patients and to try to minimize the other cofactors. So I actually made a little list here of, let's talk about late and long-term effects. What have I seen, or what do I remember over this career that's now getting close to 30 years? A fellow named Steve I treated for Hodgkin's disease, and I was very excited as Hodgkin's disease went into remission, and he developed leukemia. He got MOP/ABV, he got the hybrid, and he developed leukemia. A woman named Mary, one of the first patients I treated for lymphoma, she went into remission, or she never recurred, but she did develop a cardiomyopathy. And a fellow named Mark, who actually, one of the patients treated with head and neck cancer, developed hypothyroidism, also had a TIA. That's a small number. It's really a small number. I could probably think of a few other patients. And so then I started thinking, well, why is it that I have seen such a small number of late and long-term effects that I recognize? All right. And I said, well, is it because I'm unusually good? Is it because I'm really a good oncologist? Or is it different than that? Is it because the true incidence of late and long-term effects is low? Or are my patients just lucky? Or have I been treating people less aggressively? Maybe that's the reason. Or is it possible that my patients are not coming for long-term follow-up? Okay. So any guesses here? Am I unusually good?
Yes.
Thank you. I'll ask Rahul. Where's AJ? We'll take a vote of 2. Yeah. Well, someone pointed to the bottom one, but I'm going to, let me give you a little bit of data on that. And what I want to do probably in this second part of my talk is share some research, some of which I did actually with Rahul and with AJ and Shruti, who will be joining you as a fellow soon. And here's some other questions that I'll try to provide some answers for. Who are we seeing in the clinic? Who aren't we seeing? What late and long-term effects do these patients have? How long do we or should we follow cancer survivors? And what care are we providing to cancer survivors? So a lot of questions, but one of the ones that I will get to is about trying to answer this issue of why is my incidence with my patients of long-term issues low. So who are we seeing in the clinic? This was a study from Dana-Farber. I looked at 1 week of visits to the outpatient clinic. So there were, and as I'm presenting this, I'm like, think about your own week and how it might be the same or different. So there were 383 visits to the outpatient clinic at Dana-Farber that week. I randomly chose a week. 63% were patients actively on treatment. 11% were new and second opinions. 96% were patients had just finished treatment in the last year. So if we add that up, that's 88. Well, those numbers don't add up. My apologies. Somehow I think they got combined. But the point I wanted to make is about 80% of the patients, or 80, in fact, a little bit higher, were there for the diagnosis and treatment of cancer within the 1 year. At the bottom is really what I wanted to show. Patients who were 6 to 10 years out was 3%, and patients who were 10 years out was 1%. So 4% of the visits in that week were long-term survivors. I just don't think we're seeing them. Okay, and I'm not, and actually, I don't know if that's, I don't know that that's necessarily wrong, but I don't think, at least at Dana-Farber, that there was a lot of long-term care. This actually just looks at it graphically, maybe a little bit confusing, but if you look at nationally, about 35% of patients are within the first 5 years. If you look at the 1-week visits to Dana-Farber, that population is 90%. And when you look at the group of patients who are more than 10 years out, again, nationally, during 1 year of visits at Dana-Farber during any week. So we're not saying, we wouldn't expect to see a random distribution of survivors, but the point is, in terms of care delivery, we don't do a lot of care delivery for late and long-term survivors, for long-term survivors. Okay, so you see those names up there, famous authors. Who aren't we seeing for follow-up? Who is lost to, how about lost to follow-up? So we actually looked at about, how many patients? 487 patients who received chemotherapy. So these weren't just all cancers, so anyone diagnosed. These are people who got chemotherapy and would be considered at higher risk of late and long-term effects. Of that, 5 years later, 62% had died. So there was still a group of 183 patients who were known to be alive. And if you look at the bottom, 50% of them were lost to follow-up, and that's at 5 years. So I tend to think, let's see if I have that. This is just a graphic display. 487 entered what we call the funnel. At 5 years, 60% had died, and half of those patients who were alive were continuing to follow. I tend to think that I see my patients forever. My patients keep coming. And part of what I think is happening is I remember the people I'm seeing, but I just simply don't remember the people who aren't coming. I might say, geez, I had that guy from Hartford who had red hair, and I'm trying to think of his name. But I think actually, again, the follow-up is different than we might perceive it to be. I tend to say also, I follow my patients forever. But the fact is they're not coming. They're not coming. So with that in mind, so again, the people who are coming to the Cancer Center for long-term follow-up is not the majority. In fact, it's 50%. So what late and long-term effects are we seeing? So we looked at Dana-Farber, keeping in mind that in 1 week, in a week's period of time, there were probably 10 long-term cancer survivors. So I actually had to get a different cohort to get to 125 patients who were at 6 to 10 years and 125 who were at greater than 10 years of survivorship. And here were some of the incidents of these problems. Cardiovascular, 6% of that group at greater than 10 years had a cardiovascular problem documented. 6% in musculoskeletal complaints, 6% hypothyroidism, 2% sexual health problems. Okay, why was it so low? Because we don't ask. And it's not reported. But the point is that the numbers were low. And I thought about that a little bit, and let me just present it to you this way. For cancer survivors at greater than 10 years, 6% report a cardiac problem. But that's 6% of 1% of the visits. Okay? So the point is, 6% of 1% of a given week's visits would be with a long-term survivor with cardiac problems. It's a very small number. So even in a whole year, the number of patients that I'm going to see who are long-term survivors with cardiac problems is low. And so honestly, we don't see it that much. Now there's been a lot of discussion in literature of who should be taking care of long-term survivors. Should we? Should primary care doctors do it? Should we both be doing it, et cetera? And at least in the literature, there's been more discussion about oncologists doing it because we're more familiar with it. I actually might argue just the other way around. A good primary care doctor sees more congestive heart failure than I do. So again, just something to think about. This was how long do we or should we follow cancer survivors? And what would be valuable? What provides value? And this was an article, actually, it was Rahul, Shruti, and AJ, and several others. We just did a survey of medical oncologists. 93 of them, 61 were male, 39% female. A good amount of practice, 24-year in practice. And let's see, here we go. We asked, what is the residual risk of recurrence for patients who are, I think we defined it as 15 years out, 10 years out from cancer. Triple-negative breast cancer, 75% of the oncologists said that a patient's residual risk of recurrence was basically zero. Colon cancer, 63%. Large cell lymphoma, so not indolent, large cell lymphoma, 57%. And lung cancer, stage 3 lung cancer, about 58% said there's a zero risk. I just put this here, just to show survival curves. Residual risk would be, at a given point in time, that the further drop-off in survival essentially is zero. That the curve has flattened out. Okay, that was sort of the concept we were looking at. So this group, at patients that had more than 10 years of survivorship, was saying that the residual risk is low. I mean, it's zero. But we then asked, do those patients need follow-up? Yet follow-up for 20 or more years was recommended. So despite that, by 50% for patients who are triple negative, 28% patients with colon, 36% for lung, 40% for large cell lymphoma. So a lot of oncologists still recommend follow-up, long-term follow-up, despite the fact that the residual risk they perceive is zero. And the question is, well, why do they recommend follow-up? And they recommended it for 3 reasons: screening for late and long-term effects, screening for new cancers, and the patient's peace of mind. And I'm actually not saying these are the wrong reasons. So let me go through it again, just in my own mind. The majority said the residual risk is zero. A lot said, not a majority, the patients should still keep coming back. And here are the reasons why. So here's the question. Do we do that? Are we screening for late and long-term effects? Are we screening for new cancers? And are we helping patients' peace of mind? Okay, and I will get to that in a couple minutes. But what I will share with you is, when you actually look at the care that was delivered, I don't think it actually meets those criteria. Okay. For cancer survivors who are coming for long-term follow-up, what care are we providing? And here's some of the data. This was from Dana-Farber. Patients at greater than 10 years. Surveillance for cancer recurrence, 100% of the visits. I mean, there's a good, do you guys use Epic or Cerner? Okay. I mean, there's all the smart phrases, all the documentations there of a wonderful review systems and a wonderful physical exam and labs. So surveillance for recurrence was really 100%. Surveillance or any discussion of a focused discussion on looking for late and long-term effects was very low. It was about 20%. But here's the stuff that I actually wanted to point out too. A patient at 20 years, a man who had non-small cell lung cancer and was treated 20 years earlier, his risk of recurrence of his non-small cell is close to zero. His risk of developing prostate cancer or colon cancer or skin cancer, for that matter, is higher. And we actually do very, very little, at least at Dana-Farber. Maybe you do more here, but we do nothing close to 10%. There was any discussion of prevention. That could have been as little as saying quit smoking or I want you to be exercising, but most visits had nothing documented. And coordination of care was also about 10%. And coordination of care could be honestly as little as sending a copy of your note to the primary care doctor. So it was not a lot of coordination of care. What I took away from this was, if someone's risk at 20 years, at 10 years of recurrence is close to zero, and if all we do is surveillance for recurrence, we really haven't done anything of great value. I mean, I'll just throw my bias there. What would be of greater value for that patient's needs at greater than 10 years is yes, we should look for recurrence, and we should look for second cancers, and we should look for late and long-term effects. But really, we have an opportunity to do some prevention. And I'll just share with you, I tend to, the fellows see me do it pretty much with every visit. I say, I want to talk to you about 4 things. And the patient sort of looks at me. What are the 4 things? The 4 things are, I want to encourage you to have a low-fat diet, to have a colorful diet, to exercise more than 2 hours a week, and to move toward ideal body weight. And that part of the visit and some explanation and some discussion and sitting down and doing takes about 4 to 5 minutes. I mean, it does not take 20 minutes. It doesn't take 30 minutes. And can I prove to you that there's a benefit? No, I can't, but I think there is. Because I think as patients hear it more than one time, I do think it impacts on behavior. And I have had patients who came back, and I give them a reason. But I've had patients who come back saying, who I can see have lost weight, but they're most of our patients have a high BMI, and I've seen people lose weight. And in fact, I think I may have a slide. So what does Joan need? Okay, Joan, who's now, or my wife Joan, or Anne, who's a cancer survivor, or the other cancer survivors, and your patients. You need a medical team. You need the doctor saying, I follow all my patients. You need a primary care doctor. Other things come up, other doctors on your team. And there's just a picture of Anne. There's all these other factors, again, and some of it is the effects of chemotherapy or radiation or surgery for our cancer survivors. But there's just the other factors. There's age and gender, social, genetics, lifestyle, emotional, other health issues. We cannot impact on a lot of those. A lot of those are that's just the process of aging or genetics or whatever the other things may be. What we can impact on is comorbidities. Okay, we might be able to impact on lifestyle. Okay, we can't change genetics, though we can try to understand it. But so I guess again, this just to share with you, again, part of my opportunity with those survivors who come, small number, is to talk about lifestyle. Can't take back the adriamycin, can't take back the radiation, don't want to, because the person, God willing, is cured. But we can impact on their health risks for the future. Okay. So, and this is another book that I wrote several years ago. It's a textbook on cancer survivorship care. So again, the model has been, and a lot of this was adopted from childhood cancer survivorship, was really a medical model, and that really everything else we have not emphasized as much. This is an interesting survey from the Livestrong Foundation. They asked, I think it was about 3,000 cancer survivors in 2010. They said, what problems do you have? And just to go, we'll start at the left and move across. So they were asked, it says receipt of care, percentage of respondents who receive care for physical concerns. All right, so energy, low energy, 44% complained of that as a problem, and 9% had received some care. Concentration or cognitive dysfunction, 31%. Again, the number who received care was, it's higher. It's over 50%. But the percent who received care was 22%. Sexual functioning, neuropathy, pain. Some of them, when we get to the neuropathy and pain and incontinence and lymphedema, fit into that medical model. But and in a sense, certainly does, so does energy. All of this could be considered physical. But look at the things that I think most of us, myself included, probably don't provide a lot of care for, and I don't necessarily ask about as much. But this is what patients say. So that group of a small group who are coming for long-term visits, again, we have an opportunity to do some secondary prevention to really to hopefully impact on lifestyle, but also perhaps to remediate, to diagnose, remediate, and pay attention to all these things that they really care about. I've got some fatigues. That's significant. I don't concentrate as well. My life of sexuality and intimacy is not what it was, or it's not. It's not at all. These are difficult issues because most of us are really not, I mean, it's not been a big part of our training or who we are. But even asking the question, which I'm pushing myself to do it. I say, how are things in terms of intimacy and sexuality? And when you ask, people will tell their story. If you don't ask, they don't tell. This was another slide from Livestrong. Percentage of patients who received care for emotional problems. And fear of recurrence, 75%. Sadness and depression, in the 60 to 70% range. Grief and identity. A lot of our cancer survivors, certainly at some time of their journey, have a little bit of this or all of this. My own family. Joan had right after treatment for acute leukemia, actually had a very profound depression, very profound, which got better, but it actually took over a year. But all the other things, how does a family, we have 3 young children, who now, thank God, are 18 years older, they're adults. But, Joan had been a very take charge person in our family, running our family. When she got sick, I took over a lot of those responsibilities. When she got well, she wanted all that back, which made sense. But how do you rearrange a family after you do it? But it's actually quite difficult. Just to remind, and those things often take a long time to work out and help, and people need help. So I just share with you again, we tend to make a medical model, but all the psychosocial, all the spiritual, all the other issues are really important as well. And here, this again from Livestrong, what are the reasons that they didn't receive care? 55% learned to live with it. 37% were told it was a side effect. 20% addressed it on their own. So I don't know that we, as oncologists, can necessarily solve all these problems, but I think we owe it to our patients to bring in the right resources to try to do it. Where am I going with this is to say that I think as I at University of Maryland, as you here, think about and create survivorship programs, I think the mental health component should be a really big part of it. Okay, so a few other thoughts. Survivorship is a teachable moment and a learnable moment. It's a good time for each visit, follow-up visit, to talk about healthy behaviors, diet, exercise, healthy weight, sunscreen use, immunizations, stopping smoking, bone health, etc. Okay. Too many of our patients are couch potatoes. And so, you know what? It really takes a minute to talk to people about exercise. Every ASCO meeting there, in the last few years, there's been great information presented on diet and exercise, and let's share it with our patients. There's a problem in this picture. I always like this picture, but he should be walking up the stairs to the fitness center. But again, to promote exercise. To promote good diet. I tend to, sometimes when I talk to my patients about a low-fat diet or about dietary changes in general, I really get sort of a dubious look, like, come on, doc, food's important to me. And so what I try to discuss now is it more realistically. I said, what, doesn't mean that you can't have any fatty food, it just means try to move in that direction, try to move toward ideal body weight, try to eat a colorful diet. I also want to share, too, that I think cancer survivorship can be a growth opportunity. This is a very good book called Super Survivors. Lee Kravitz is a cancer survivor. He had testicular cancer. He's a psychologist. But they really talk about not just bouncing back after illness, but bouncing forward, which I think is a really a very cool concept. That not only can people get back to where they were, but they really can go to new places. I think in many ways, again, Joan having had leukemia was terribly traumatic, but it, in a sense, was not that we would have chosen it, but has been a growth opportunity for us and for each of us individually, together as a couple, actually for our kids as well. One is a psychologist, one is a social worker, and one's in medical school now. Oh, this is a long slide. Couple words. So there is essentially a rule from the Commission on Cancer that we need to do cancer survivorship plans. Patients should get a treatment summary. This is let me just sort of summarize. If you were to ask me, well, are they valuable? This is a slide that says, yes, survivors who got the intervention, the survivorship care plan, reported more attention to depression, hot flashes than those in the control group. This is another slide that basically said that giving us a survivorship care plan is not cost effective because it really didn't have a lot of impact. So I think it's a useful thing to do. I think what's more important, however, is I would encourage you, is what I would call a living care plan. Living care plan means that it becomes a teachable moment, that it's not just handing you a piece of paper that summarizes how much adriamycin you got, but it's really focusing on healthy lifestyle. We did, this is several of the other residents at Sinai Hospital. Sinai is a large community hospital. We looked at physical activity before and after several counseling sessions with patients. We found it was feasible. Most of it was video-based. We either emailed links or patients came to watch 6 videos on healthy lifestyles. It was only 30 patients. It was randomized. But just to share with you, we started to see some change in physical activity. Not enough to prove it, but it can be done. You can, and I just encourage you to really, it's not just giving people a piece of paper. Okay, so I think I'm down to 2 slides. What don't cancer survivors need more of? I don't think they need more surveillance for recurrence. I think we're doing a good job. I don't think that they need long or longer treatment summaries and survivorship care plans. Okay, I think because I'm not sure that that's where our success is going to be. What do they need more of? They really need more. So what can we do is more secondary prevention, because as people are living longer, the chance of getting a second cancer is high. About 16% of visits to the Yale Cancer Center were cancer survivors coming back with new cancers. Low-fat diet, colorful diet, exercise, ideal body weight. We should really promote our patients to have adequate screening, cancer specific to their diagnosis, but also everything else. How many of our patients, when we ask a woman who's had breast cancer at age 40, at age 55 has never had a colonoscopy? And the answer is as many as the rest of the population. It's about 60% screening. Screening for late and long-term effects, and then action, doing something about it. And it also means asking about psychosocial care, including sexuality and body image. And we can't necessarily do it ourselves. I'm not a sexuality counselor, but it's good to have the resources. Coordination with primary care is really important. It's easy to get lost in a big cancer center. And then the other thing I'd mention is the concept of transition to primary care. It's really okay to discharge patients. Doesn't feel good because, we've been through this journey together. But the fact is a lot of us fellows are graduating, moving on. The attendings are transitioning sometimes as well. So planning transition is good. Again, there are, just so to summarize, there are seasons of survivorship. Fortunately, 70% of our patients are late and long-term survivors. Most of them are doing great, but it really is an opportunity to promote healthy survivorship. What I like to call it is living well beyond cancer. So, thank you very much. Thank you.
Thank you for sharing that important information. Thank you for sharing your story. I really appreciate it. You reminded me that some years ago I was asked to go to a delegation of the American Heart Society to St. Jude.
Mhm.
And St. Jude had published a couple of papers in JAMA showing increased abnormalities in pulmonary function tests in adult survivors of childhood cancer.
Mhm.
And so that was the discussion about should we be evaluating people with pulmonary function tests, what is the expectation if pulmonary fibrosis is going to happen, and all these things. One of the issues that was discussed there, and I want to bring up to this one, is the issue of race and gender and ethnicity, and how I suspect your numbers will be even smaller in those who are non-white. And that's an area that we're all getting worried about, the issue of diversity in healthcare and how we impact it. Can you tell us a little bit about that?
No, actually, it's a very good point. I think, well, firstly, I think follow-up rates, I suspect, may be lower in underserved populations for a variety of reasons. Comorbidities tend to be higher. So in a sense, the group of cancer survivors who may need the most intervention, which are African American, Latina, patients from other cultures, are probably who need us the most or need health care the most, are probably getting the least. So it's the same issues that are affecting the general population, but when put into a cancer survivor group, are even more important. There's some good data, by the way, from City of Hope, where they have a very large Latina population, but their breast cancer survivors' follow-up rates are even lower.
Questions or comments?
I wanted to ask a question about the transitional survivorship. Can you say that it's beneficial for patients to have a dedicated clinic visit to discuss survivorship issues? And should that be something that is automatically made for them, or should it be a referral based for looking at something necessarily?
So I think the answer is be yes, yes, and yes. So, but I'll tell you why. Yeah, I think it should be automatic. Again, a lot of patients aren't going to follow up as long as we think they are. I mean, some patients will really trail off after 2 years. So I think having people come after they finish treatment for in a sense, a lot of it's a wellness visit, to go over their treatment, to talk about problems they may be having, and to pay attention to them, to do some cancer, to help set up cancer rehab if needed, but then also to talk about good health. They may never have had that. So I do think it should be automatic. It does not have to be a referral. I would a lot of the resources at a cancer center are available free, including typically social work, some exercise counseling, some navigation. A lot of that should be free and just available. And I think that the bang for the buck is really good. So automatic, non-referral, and pretty much for everybody, my opinion. Yeah.
In terms of your extended survivorship, you're maybe not seeing as many people coming back. I think it's hospital fatigue. They just don't want to be in a hospital anymore.
Yeah, I mean, I think that's part of it. Some people will say, listen, I've been through that already. I don't want to do that. And especially because often people have seen, with breast cancer, seen their surgeon and their radiation oncologist and their plastic surgeon and their medical oncologist, like enough already. It's not good health utilization. They're also having a bunch of tests. So I totally agree with you. Some of it is they may have other health issues that simply become a bigger priority, and so they're not coming back as well. But knowing that people aren't going to come back, we should actually build it into how we take care of people instead of fighting it. Yeah.
I just thought about something. You had something, Doug? Go ahead, please.
So at bigger centers and in the literature, you hear this development of multidisciplinary survivorship clinics, and I've always thought that is a good idea concept, but practically not because of the reasons that you're talking about. And I agree with you also that it should be more built into the routine visits of oncology. Have you seen any of these? I'm sure you have, in terms of where you've been, multidisciplinary clinics, and what is the benefit to those therapies?
Yeah. So it's a good question. In terms of what do I think are the core services? So what we're starting, what we did at Sinai, what I did at Dana-Farber and at Yale, is patients would come for 2 hours. They would have 4 sessions. They would see a medical provider, which either a nurse practitioner or their doctor, could be their oncologist, just to talk. Often it's a follow-up visit with a focus on survivorship issues. They would see a social worker to have a half hour to talk. Now, many of those, and it's typically the best part of the visit. They would see a dietitian to talk about the concept of fighting cancer with a fork. And at least in some of the programs that I've done, we've had a physical therapist or someone exercise-oriented to talk about wellness. So those have been the 4 components. From that, and then the providers, the patient stays put, the 4 providers rotate rooms every half hour. So all 4 patients are seen by 4 providers. And so we did that once a week, or eventually got up to twice a week. So about 8 patients a week. Patients who then need referrals, more for long-term mental health, which wasn't that common, or wanted to work on diet, or wanted to follow up with the exercise person, could do it. So that was useful too. I found doing it actually the University of Maryland is small. It's around the same. It's much smaller than the other centers, and in some extent doing this at a smaller center is easier, because it's sometimes easier to get buy-in from dietary, from social work, from physical therapy. At Dana-Farber, for example, we got very complicated about paying 0.06 FTEs and benefits, to buy a certain amount of time from the physical therapist. It was somewhat unpleasant. So I think if in a center, I'm going to suspect that you've got a good group of people, and I would hope that you'll be able, you could piece together the core elements without having to buy it. Good. Yeah, they're getting buy-in, and hopefully I'll have a chance to meet with you guys. Getting buy-in to survivorship is actually challenging for many reasons, including clinicians often say, well, I do that already. Don't refer their patients. And actually, so I agree with you. I think it should be automatic, just part of what we do. But I really do think it's valuable. I think patients remember it. It actually adds to satisfaction, and we can't prove outcomes yet, but I bet there will be an improvement. Just a quick thing with the plenary session at ASCO, there was a prolongation of survival in patients where we did good symptom management. All right, so I have to think that if we do this with cancer survivors, it'll be the same thing.
Well, before we finish, I want to remind you that we start again in September. Is that correct, Jason? Thank you for coming throughout the year. I want to get you energized to start again. We're going to be more enthusiastic about getting you here on Thursdays to grab rounds. I want you to take the example, perhaps of Arnold Forrest, who wins the award of every year coming every day. But I want you to take the example of this man, your previous chair, who's in this chair every Thursday morning. We appreciate it. Okay?
Wow.
The other thing I want to do is that we have a tradition here for only great speakers. If not, we
you slug them.
But we also want for developing a tradition of having a Louisville Slugger bat at every academic institution in the United States, and we're getting there slowly. Okay, so this is Kenneth D. Miller, 2017 Theodore Segal Lecture, University of Louisville, June 8th, 2017.
That is really nice.
Thank you, sir.
Thank you very much.
You guys have a good day.
Thank you. Actually, I want to thank the Segal family also. Really appreciate it. Thank you.
We're going to take some pictures with you with that.
That's
and
great.
We'll
Love
mail
it.
to you because you won't be able to get it.
I was actually wondering that. That's the first thing that I thought of.
So much.
Yeah, thank you. Nice to be here.
Thank you. The doctor who was dragged out of the way, and everybody got